slightly different audience for you today. We have social care providers today whose workforces are largely mobile and who, subject to the restrictions that we're all subject to, the people they support are also largely mobile. So there may be some different kinds of issues that are coming up around the risk of transmission and so forth. Before I go any further, could I ask everybody to please put themselves on mute if they're not on mute, because we're getting a little bit of chat on the side. That's really helpful. Thank you. A couple of things about the rules of engagement today. First of all, we're recording this, so just be aware of that, please. The second thing to note is that we've got a lot of people here, and we cannot realistically give everybody a speaking part. So if you have a question or you want to raise a point, can you please do that through the chat function? And we have a number of the team who are going to patrol the chat function, gather up the questions, and then we will relay them to the speakers afterwards. And thanks to all of those who submitted questions in advance. When our presenters have finished their initial presentation, I'll kind of ask those on your behalf, and then we'll catch up on other themes that arise. So I think that's kind of all I want to say as by way of introduction. Jason, I think I'd like to give the floor to you. For those who don't know Jason, this is Professor Jason Leitch, who is the National Clinical Director of the Scottish Government. We also have speakers, and I'll introduce them when we come to them. Jason, I don't know if you want to say anything more about yourself than that, but please be my guest if you do, and I'll just hand over to you at this point. Thanks.
Thanks, Danny, and thank everybody for coming. I can't believe you've given up a lunch hour in this large number. Surely you have more interesting things to do than listen to us. But thank you for giving the time. Fortunately, as I've learned throughout my professional life, I need experts, so I have brought a couple of them. And if there are tricky questions, Syed and Mary will answer them. Syed is our resident Scottish vaccination expert and has been in the vaccination world for some time, and will be able to help us if it gets a bit tricky. I'll try and do the layman's version of some of that just now, and then we'll see where we end up. What we intend to do is to try and answer as honestly and as openly as we can anything that's worrying you, your constituent parts, those you serve, those you work with. But let me apologise up front in that I don't understand your context, so forgive me for language mistakes, or if I don't understand what it is you do for a living. I have some understanding of your sector, of course, from this job, but I can't walk in your shoes, but nor can you walk in mine. So let's try and get you answers to what would be helpful to you. So let me do a little bit of an introduction. It won't take us long around what vaccines are and where we are on the COVID vaccine rollout, and then we can talk about some of the perhaps more controversial or questioned areas as we go on. So let me start here. There isn't any doubt that Edward Jenner's invention of vaccination many decades ago is the single greatest public health measure in history, other than our ability to clean water. It has saved more lives than any other single intervention in healthcare history globally. There is absolutely no question about it. It is safe, it is effective, and it is actually an astonishing piece of science. Just to illustrate that, here are 3 vaccination stories told very quickly from left to right in terms of time. So if you look at the top, the size of the circle is the number of deaths from this disease globally. So this is diphtheria. You can see in the early 20th century, a consistent killer throughout those 30 or 40 years. You introduce vaccine in about the 50s, 40, 42, 43, and diphtheria disappears from most of the developed world. Literally disappears. When I was training, I never saw a diphtheria case. I have now seen diphtheria cases because I do quite a lot of work in India, where it is not completely gone. And then whooping cough, you can see the same old story, introduced in 57, a couple of outbreaks later on, a couple of times where vaccination has needed adjusted, or people haven't done it quite so well, and then a longer and more complex story globally of measles. We get the vaccine on the year I was born in 1968, and then a gradual reduction in the disease globally. Remember, this is a huge disease with a massive R number. Remember the R number for COVID that you've heard us talk about a lot. We're trying to get below 1. Well, the R number for measles is between 15 and 20. So a very, very infectious disease and hard to eradicate. But now, apart from very recent years, pretty much gone from most of the developed world. A little bit tricky in the last few years because of an anti-vaccination community who have suggested that you shouldn't have your measles vaccine. To be absolutely clear, this illustrates why you should have your measles vaccine and your children should have it. So vaccines work and vaccines are safe. This is how the vaccine works. The red blob is the coronavirus that causes COVID. COVID is the disease. And the coronavirus actually looks like you've seen on the telly. It's a globe with spikes. And the cartoon version of it is about right, actually, if you look at it down an electron microscope. And what the clever scientists do is they take a tiny piece of the spike, and that spike is how the coronavirus attaches to cells. And all the coronavirus wants to do, remember, is get in the cell and divide. That's its only purpose. It just wants to replicate itself millions and millions and millions of times. So we take a little piece of the genetic material of the spike, we put that in some kind of transport medium, sometimes an inactivated virus that doesn't cause disease, sometimes just the RNA, the DNA itself, and we inject it into an individual. And when you do that, your body gets tricked into making antibodies to the spike protein. So those antibodies don't do anything because there's no spike protein to attack, but they just wait. You imagine them sitting behind a rock waiting for the real virus to arrive. But we have pre-activated that system. And when the real virus arrives, they kill it. It's as simple as that. That's what a vaccine does. There are layers inside there about whether it's antibodies or the cells or what happens. But fundamentally, that's how a vaccine, we pre-prepare your body to attack the actual disease. And that's what the COVID vaccine does. And then when you meet it, we can release those antibodies to attack it. Now, one of the questions, and legitimate questions about the COVID vaccine, is how did we do it so quickly? How did the world do it so quickly? Because normally it takes 15 years or more to go from disease to production. Well, we shortened that by not doing each stage consecutively, but doing them simultaneously. So we took risk, is how we did it. Risk for money, not for safety. So governments, the WHO, the UK government, other governments, decided to underwrite the drug companies' risk effectively. So you can see the phase 1, 2, and 3 trials overlap. Normally you would do phase 1, phase 2, phase 3, and you wouldn't produce the vaccine until all the trials were finished, all the regulation was done. We didn't do that. We did vaccine production before regulatory approval, but didn't give it to anybody. And we may have had to scrap all those vaccines if they weren't approved. But that, fortunately, from the trials and other regulatory approvals, didn't happen. So we compressed the timescale by reducing the risk of the drug companies not being able to do it, because it's an enormous investment to make a vaccine. And we also have got better at the technology, so we know how the vaccines work. And we can now make vaccines much quicker than we used to. So that's the other way we got that shrunk down. So there has been no corners cut in terms of safety or in terms of regulation. And the boffins at the Joint Committee and the MHRA would not have approved these vaccines if they weren't ready for approval. So that deals with some of the challenges of people thinking we've done this too quickly. And then we have a number of vaccines now coming on stream. You've probably heard of these four. There are others now. The UK has bought about 360 million doses of vaccine. We won't need all of them, but the UK vaccine group had to kind of put its poker chips on which vaccine was going to come first, and that's what we did. And Pfizer came first, followed by AstraZeneca, and Moderna will be next, probably in April, but it presently doesn't have regulatory approval to be given. So we need more trials. We need the committees to meet again. And then the Sputnik one is the Russian one. There's also a Chinese one. There are a number of others. There's Valneva, which is being manufactured in Livingston, but probably won't be ready until the summer. So lots of companies, and we need as many of these as we can get, because we need, for Scotland, for just one version, 1 year's worth, we need 9 million doses. So that's quite a lot of vaccine. And then just before I open up to questions, this is a graph of why we start with the old. So this is your risk of death from COVID. So as you come down that curve, your risk of death falls. So you can see that you start with the elderly, healthcare workers come in to that bit, but that's principally to protect those they care for rather than protect themselves. That's the only professional exemption on the age curve. Then those with comorbidities or other diseases, and then you can see the 60 plus group, the 40 plus group, and then we go to everybody. This is perhaps a neater way of explaining that priority group. So this is the number of vaccines you need to give in order to prevent one person dying. So in the over 90 age group, you need to find 40 of them, vaccinate them, and you will prevent one death from COVID. In the 50 to 54-year-old group, me, I'm 52, you need to find 40,000 people my age to prevent one death in my age group. Now that's averaged across the whole population. It's not an exact number, but it gives you a rough idea of why the Joint Committee said start with the elderly and work your way down. Because vaccination at this point is about preventing individual risk of death, not about population level vaccination and protection and immunity. But we will come to that, of course, as we do more people. And then even more bluntly, this is how many vaccines you need to give to elongate life by a year. So to save 1 year of life, and it's only 10 vaccines in those over 90 and 130 vaccines in those over 50. And this is the order. So this is the UK-wide order. These are UK numbers beside the groupings. So care home residents and workers first, because they are the most at risk. Then the over 80s, and we're now into group 3 and 4, as you've seen. And we're making very good progress to finish those two groups by this Friday. In the main, there will be a few stragglers, of course, but across the whole of the UK, we will finish group 3 and 4 by this Friday. We'll then, and we have already started group 5, the over 65s. And then group 6 is not only the biggest, but also the most complicated. So that's everybody with underlying health conditions, the flu vaccine group with a few edgy changes in there. And then we work our way down through the ages. We have said, pending supply, we will get all 9 of these groups done by May, and that's still our intention. Although supply in the next couple of weeks is a bit lumpier than it's been in the last couple of weeks. So numbers will fall a little bit compared to our record numbers yesterday and today and the day before. So that's why we're doing the age groups in that order. This is our progress against other countries. So this is everybody who's trying to vaccinate fast. And this is the number of doses we've given per 100 people. Israel ahead of the league table. The United Arab Emirates is next. The Seychelles has just come up on the outside wing in the last couple of days. Pretty small, but they've done an amazing job. And then the UK, we've got to 10% of those 100 people. This is a few days out of date now. It needs updated, but this is kind of where we'd got to a few days ago. So this is 98% of care home residents. We're now over 99%. You can see the other numbers. We're finished the 80s and we're finished the health and social care workers. And now we're moving into that next group. So that's my introduction, Annie. Let me just stop sharing. There we go. And whoever's in charge of questions can now take over.
That's lovely. Thank you. Thanks very much, Jason. Very, very clear, very succinct. I've got some questions that came in prior to us starting today, and we're starting to get a couple in the chat. Excuse me. Can I just ask, Alison, do we want to kind of have the other speakers come in now, or will we have some questions for Jason in the interim, and then have Saeed and Mary afterwards? How do you think you want to do this?
I'll pass them, Annie. They'll be.
You'll pass them on. Okay, that's fine. Thanks very much. In that case, can I go straight back to your slide about the effectiveness of the different vaccines? Because we have some questions. We have some questions about that. What's the relative effectiveness of each one, and how are decisions made about that, and who gets what? I think also there's something that came up that I don't think you touched on, Jason, that has come in from several of our members, and that's about some of the messaging around the interval between doses. Yep. Which has changed, I think, over time. So if I can just chuck those two to you first of all.
Yeah, and Syed will come in and give a slightly more technical explanation of some of that. The fundamentals are they're all as good as each other. The research has slightly different percentage levels, but we are confident that the two we're using just now, Pfizer and AstraZeneca, are effective, and they're somewhere between 70 and 90% effective. It's difficult to be absolutely definitive. No vaccine is 100% effective. For instance, the flu vaccine prevents about 60% of disease. The COVID vaccines presently seem to do very well at high disease, so severe disease, hospitalization, death. You can still maybe get moderate disease, mild disease, but you're much less likely to pass it on if you have mild disease, etc., etc. So we're very confident that they're all protective. We're also increasingly confident that we haven't changed the range. We've always said 12 weeks between first and second doses. That's what the Joint Committee said, and we've followed those instructions. And research again last week from AstraZeneca suggested again that 12 weeks is actually more protective than 3 weeks. It's counterintuitive that if you wait longer, you actually get better protection. I realize that, but it actually follows your immune system. So you build up immunity, number one. We give you the second injection, you get elongated immunity and better immunity for a longer period. So the by 12 weeks is what we're sticking with. We will allow some leeway in there. I mean, if you get it at week 10 or the day after your 12-week anniversary, that will not do anybody any harm. It's not as exact a science as that. But fundamentally, first dose, and whichever vaccine you've had, you'll get that vaccine in your second dose at around 12 weeks later. The other question in there before I ask Syed to come in is people are concerned they won't get the same version. You will, but in time, we'll probably realize you don't need to. Nobody usually cares where their vaccine came from. And if you've had a typhoid injection, for instance, for overseas travel, you've had a booster that wasn't the same as your first one. And we're doing trials just now that will show we expect that it doesn't matter which version you get and it doesn't matter which order you get them. But for now, your second will be the same as your first. Syed, anything else?
Thanks, Jason. Thanks again for inviting me as well. I think you probably covered most of the key points. Just to supplement what Jason said was that I think you probably hear lots of numbers being bandied about before those vaccines. But one thing is quite clear. These vaccines, the data are not comparable because they're not designed, the clinical trial or not designed exactly the same way. So they're slightly different. But as Jason said, the most critical thing to look at is the most severe infection. What impact these vaccines have in protecting lives. I think that's the key aim of the program initially. And if you look at all these vaccines that have been authorized to use in this country, although there are 3 vaccines authorized, we only got 2 of them. We don't have the Moderna yet available and unlikely to be available until April. Both of those vaccines, the efficacy against severe illness, both admitted to hospital, ITU, and death, is over 90% for both of them. They're comparable head to head. But when you look at some of the data regarding called the interim sort of effectiveness after first dose and second dose, the problem with the data is that because the vaccine have been produced and we've been using quite rapidly, the companies simply did not have enough time to collect the data about the duration of protection after the first dose and after the second dose. Now, the vaccine manufacturer Pfizer is the one that basically said they do not have any data beyond 3 weeks efficacy of the first dose. And the main reason why they said it mainly because they did not have the data. Now we are beginning to get data because you'll be collecting data both in Scotland and rest of the UK. And as Jason said, there's the article published in the Lancet last week, the scientific journal, where they did present data, the effect of the first dose vaccine after 3 months. And it's quite clear the effect remained quite high, and for 76% after 3 months after the first dose. And as also Jason said was that the way the vaccine work is that the first dose you call the prime the immune system. Our immune system became primed, and the second one is to give a big boost, but also give longer time protection. And that's why we tend not to give vaccine too close to each other. And again, the data suggests that if you give a longer gap, 3 months rather than 3 weeks, you tend to get a longer term protection. Again, these are new data emerging, and JCVI, the committee, the scientific committee that advised the UK government, are closely monitoring the effectiveness of both of the vaccine on a week by week basis. And if there is any doubt and any drop in the vaccine efficacy, they'll immediately advise all the UK government accordingly. But at the moment, we have no reason to doubt the strategy we're following in the UK. Over.
Thanks very much. That's really helpful. Now, I was very negligent in not introducing you before, Saeed. So you have just been listening to Saeed Ahmed, who is Senior Medical Officer at Scottish Government and a specialist in immunisation. I'm very grateful for you joining us today. A couple of questions coming in the chat. I'll pick them up because they were in my kind of list beforehand. The first one, colleagues, is about side effects. You will know perhaps that there is some concern, particularly amongst a largely female workforce, that there may be side effects, longer term side effects on fertility and so on. So I'd be grateful if you would address that. And also for staff who have allergies, if there is any kind of hesitancy that tends to be about that kind of thing. So if you could address that. And also, what do we know about the future need for ongoing kind of boosters? Once we've got through the first rollout, it may be annually. This is the kind of thing that people are now reading. It would be really useful to have your view. Before I do that, could I just say again, colleagues, if you're not speaking, if you could turn your camera off, that would be really, really helpful. Not that we don't want to see your living room. We do want to see your living room. We're always very interested in that. But it just helps people to focus on the speakers rather than everybody attending. If you could do that, it'd be really helpful. So thanks for that. And Jason and Saeed, side effects and boosters, please. Thank you.
Yeah, so they're both relatively straightforward. One is more certain than the other. The side effects are short and limited of all vaccinations. These are not drugs, remember. This is not something we're giving you over a long period. There is no biologically plausible reason why fertility would be remotely affected. So it is, forgive the bluntness, nonsense. And it is not a risk from vaccine at any level. There are, of course, some very short-term side effects, and that is a bit of a sore arm. Some people get a sore head, and some people get a little bit of a fever. And that's about the production of the antibodies. Those short-term side effects are about antibodies. But antibodies are a natural response. They're not something your body will try and get rid of. They're not something that will make you sick, and you do not get the disease. So there are no long-term side effects of these vaccines. The other short-term side effect is, of course, allergy. It's not really a side effect, it's a result. And we've seen it a few times, particularly with the Pfizer vaccine, in people who have been allergic to one of the elements of the vial, not the actual active drug, not the vaccine itself, but one of the preservatives that go in it. And AstraZeneca doesn't contain that. And if you are allergic, historically, you'll have a conversation. Remember, vaccination is a medical procedure, so there's a conversation with somebody. It's not we line 100 people up and come along with a big syringe and inject them all. There's a consent process for whoever's being vaccinated, whether it's a resident, a worker, a healthcare worker, or somebody in the community. And at that point, you would have a conversation about your history. And if you've had an allergic reaction to vaccines before, or if it's a penicillin allergy, people are not going to worry about that for vaccination. But there'll be a conversation in which you can have those things dealt with. And it may be, if you've got allergy history, you might be redirected to the AstraZeneca vaccine, which is the bulk of our vaccination just now anyway, actually. Boosters, we don't know, but most of the mainstream science suggests that, yes, we will probably need annual COVID vaccination, a bit like flu. It depends what the virus does, and it depends where we are in terms of prevalence globally, but we think it's probably going to be necessary for at least the foreseeable future.
That's great, thanks. Do you want to come in on that one side?
Yeah, if I could just add, I think Jason covered most of the points, but as Jason has already showed in the slide, remember, this vaccine is made from a tiny bits of the genetic material of the virus, the DNA and the RNA. There are no live viruses in our body. We are not injecting any live viruses, although a live virus is used to carry the bit of the DNA, but it kills off very quickly. It doesn't multiply in our body. So there is no biological reason why it should cause any problem. I am aware that some young women are concerned about fertility, but there's absolutely no reason why that should be the case. Now we have given more than 12 million people the vaccine in the UK. Majority of those initially were professionals, doctors and nurses and other staff. And certainly we got data now for on nearly more than 12 million people being vaccinated, and the MHRA, the regulatory body that actually monitor all these and license the vaccine in this country, they have published their report last week based on the first few million people, and they have basically confirmed that they have no concern whatsoever about the safety of any of the two vaccines you are currently using, in fact, in this country. So I think that's the important message, that we have absolutely no reason to believe it is going to affect the fertility or affect the baby in case they're pregnant at the time the vaccine is given, because it doesn't simply make any sense, because there's no live virus and it's just a piece of the DNA we are giving. We are not giving any drug or anything like this that might cause any problem, although we are aware that people are always hesitant to take anything during pregnancy, which is quite right and proper. And Jason also mentioned about the allergy, as we got a screening questionnaire. So they'll be asked a standard lot of question, and anybody who say yes to any of this question, they'll be simply set aside and either will be offered a different vaccine or someone else will talk to them. So there is no need to worry about anybody with allergy. It's only those with a severe allergy, many anaphylaxis reaction, that can't have the vaccine. Vast majority of the people with minor allergy is not a problem. And finally, I think Jason said, the $60 million question, exactly where we are with this virus. Clearly, if the vaccine are good, and if you think they are, and if you can get a very, very good uptake rate, maybe you'll be able to get rid of it, but I doubt it, because vaccines, the virus is always trying to be step ahead of us, and you already heard about the variant type, and they try to be clever like the flu vaccine. As you already heard, the flu virus is very clever. The flu virus changes much quicker than the coronavirus, and that's why you have to produce a vaccine every year, because you have to adapt the vaccine to fight the latest the strain that is in circulation. We are hoping we will not have to do as frequently as this one, but we don't know yet. We just have to wait and see. But clearly, whatever whatever way the virus behave, we'll make sure that you got the armament in our tool to be able to fight it. Over.
That's incredibly helpful and very, very clear, I think, from colleagues there about to dispel the worries that people have about how this may or may not affect people. Very, very clear. Given that that's the case, Jason and Saeed, we've had a couple of questions in the chat already, and it has come up prior to this, about the view being taken within the Scottish Government about whether vaccination ought to be compulsory or not. for health and social care staff. At present, we know it isn't, and our colleagues at the Scottish Social Services Council have made it very clear that it's not conditional for registration, but it's a question that keeps coming back. So very interested to have your views on that, please.
No, there are no plans to make it compulsory in either a registration point in time or in an employment point in time. All of the advice from behavioural science, and it's a separate group of scientists from the clinical scientists, is that actually what you should do is you should use persuasion, science, evidence, peer pressure, and individual relationships in order to build up your vaccine percentages. And that works much, much better than forcing. Now, I can't tell you that that will forever be the case. We do have a couple of examples in the world where we do insist on vaccination for certain things. So some of you may have been in exotic countries where you have to take a yellow fever certificate in order to get into the country. That is one global example where the WHO give you basically a yellow fever passport in order to travel to some countries. That may happen in the future, but not for a while. The other example is hepatitis B vaccination for clinical teams. So I have a hepatitis B vaccination certificate to allow me to be a surgeon, although that seems like a long time ago now. So there are examples where we have made it a condition of employment. We do not anticipate that happening with COVID just now.
Again, very clear. Thank you, colleagues.
Can I just ask, Craig, so the side effect, as soon as you answer the side effect question, somebody then always says, but you don't have long term. How do you know there's no side effects? The reason we know is the vaccines are all the same. We adjust the DNA of the vaccine, but the fundamental technology has existed for 150 years. And you do not get side effects from vaccines. So that's how we know there are no long-term side effects.
Okay, thanks very much. I wonder if we can move on now to the slide that you put up about the priority groups and the order in which people are going to be vaccinated.
I'm going to shut my blind. Keep talking.
Yeah, I was going to say you're getting snow blindness there probably. So one of the questions that came up in the chat again echoed some concerns we'd had raised before. Where obviously we're very pleased that social care workers are included kind of pretty high up the priority list for that alongside our colleagues in the NHS. The question that has come up, if the vaccination of social care workers is important in order to protect the people we're supporting, some of the people we're supporting are a bit much lower down that list. So how do we kind of work that out in relation to the protection of the people we support when their workers are vaccinated, but they are not? And we're talking about some of the younger people here. I mean, one of our kind of quite significant constituency of membership, for example, would be people working with children and young people. And are classified as social care workers, but also younger people who have complex needs who may not be as high up the list as others. So if, in short, if we're vaccinated as workers, but the people we're supporting are not, how do we kind of work out the logic of that?
Because we had to categorize. We had to have big categories because it gets very complicated if we're going to say, right, if you're caring for somebody who's over 34 and a half years old, who has this list of diseases, then you're eligible. But if you're looking after somebody who doesn't have one of these diseases and has never had an aerosol generating procedure, doesn't need artificially, so you can see how complex it gets really, really fast. It's already complicated by having a vulnerable group now, and then another vulnerable group in group 6, as you saw. So the Joint Committee took a view, and we accept the Joint Committee's advice always. We've never departed from it in 30 years. In fact, in England, it's the law. You can't depart from it. We do have choice, but we've never chosen to depart from it. So you take health and social care workers as a big group, frontline health and social care workers, and you decide we're going to do them all. Now, there are some in there. So you could argue my old job as an oral surgeon, not dealing particularly with the elderly very often and the vulnerable, never in a COVID ward. Now, you could argue, actually, in my world, I probably wasn't a big risk to others and those I served. But in order to categorise the whole group, the Joint Committee decided to put everybody in it. And the categories of vulnerability are also about doing that. So just now, we're doing the shielded group, formerly shielded group, and then we're going to move into that big group, which is more complex, of those who get the flu vaccine and some others. So that's why there are some anomalies in there where you might think, why have I had the vaccine and Frank, who I look after, hasn't? That's why.
If I could come in, I think you already seen the slide. I think what it shows is that certainly from the COVID point of view, if you look at the risk of COVID complication, when you look at the data of people who actually either admitted severe COVID and also died from COVID, if you can actually protect everybody over the age of 50 with vaccination, that covered nearly 99% of death from COVID. If you can protect everybody over the age of 65, you cover 90% of the death. So that's why the JCVI said we need to protect those who are most vulnerable, the elderly, those in the care home, and people with got serious clinical condition. Clearly, health and social care workers, as Jason says, they are, quite often work with certain groups. So the children, unless they are in an institution with a severe, called the neurological problem, they are not at high risk of complication from the COVID point of view. And as Jason said, quite often health and social care workers, for example, there are people who work in hospitals, and they don't necessarily work with elderly people, but hospitals in an environment where people mix all the time. So chances are they might come into contact with someone at high risk. So it is very difficult. That's why to sort of draw a line. And that's why it does seem a bit odd for health and social care staff. But if you look at all the patient group, it's quite clear we are targeting the elderly, the most vulnerable first, and then working way down the age group. Over.
Great, that's really helpful, and that confirms a lot of the discussion that I've had, as a member of the Cabinet Secretary's mobilisation group, for example, where the priority here is about reducing mortality. That's what we're all about here. Would you say that's what you're saying, Jason, isn't it? In effect, the priority list is really about reducing mortality.
Yep.
Yeah. Absolutely. Okay, we have another couple of questions, and particularly for the groups of people that our members support, which includes people with autism, for example. The question is about other methods of vaccination other than a jab. I started the session today with a song from Mary Poppins about a spoonful of sugar. It makes the medicine go down, and there have been other ways of immunization developed that don't actually involve a needle. So for people who have issues with needle or find it very difficult to accept a needle, are there other ways of doing this, or is it just the one way?
Not yet. Technology will change and improve, and companies are working on it, of course. I imagine there will eventually be nasal sprays and patches and other ways of doing it, but for now, the delivery system is, unfortunately, a diluted vial of vaccine. And it's simply to get the manufacturing done as fast as humanly possible, because we need to vaccinate the world, not just Scotland. So the little vials you see running around on the BBC factory are the way to do it just now. But companies are working on other forms. The flu vaccine took many years for us to get the flu vaccine in nasal spray for children, but that will eventually come.
Okay, thank you. We have another question, which is about a specific group of social care staff, and that's the ones who have up to now been shielding themselves because they have particular vulnerabilities, but they are still part of the workforce. So we've got a couple of questions in the chat, and again, this came up before. What's the timeline, or what's the stage at which those workers are able to re-enter the workforce, and what kind of bearing does vaccination have on that for them?
For now, vaccination has no bearing on behaviour, none. So vaccination does not let you do anything that the rest of the population can't do. So that applies to the shielded group as well as everybody else. So for now, the shielding advice is as it is. Remember, the shielding advice to stop working is quite recent. We had the shielding group at work doing risk assessment at work and making decisions about that up until the 4th of January. So only when the prevalence really kicked up did we redo that advice and say, once again, we need the shielding group not to go to work. We will change that when the prevalence falls, not directly in relation to vaccination. There's then a deeper question, which is what will vaccination do to our behaviour, not just for the shielded group, for those who want to travel, for those who want to go to the pub, for those who want to go to the sporting occasions. We don't know yet. But eventually we'll have to give scientific advice, and politicians will have to make choices about what vaccination means for behaviour, but we're not anywhere near there yet.
Okay, thank you. We have another question about new staff coming on to the workforce and how they will or won't be included in this.
They'll be included like the present workforce. So if the health boards will need a way, already have it, because health boards are employing people all the time. There are massive incoming and outgoing all the time, and social care has to be able to do that as well. So the vaccination will be available to new workers coming into new settings.
Okay, thank you.
And just to add, that, as you know, as well as health and social care staff, we are working our way down the age group as well. And other, so some of the people who are coming into the workforce may have already had it because they're eligible for other reasons. So certainly our plan is that by end of May, we're going to target everybody over the age of 50. And by the summer, hopefully, are targeted almost all the adults. So certainly, we are working our way down. But if they are much younger age group and remain unvaccinated going into this profession that put them in high risk, yes, we will make sure they get vaccinated before they start or as soon as they start. Over.
Okay, thank you. I've got a very, very specific, this is the last of my kind of pre-prepared questions and the ones that are coming down the chat now. It's actually quite specific, but I'll chuck it at you anyway. And it's about the difference, or indeed the similarity, between what we would call housing of multiple occupancy, HMO, where you might have people living together, people with a learning disability or mental health issues living together. And some of the public health advice that our members have received is that they ought to be treated, in terms of risk, the same as a care home, because people are living together. It's a congregate setting. So I guess we're wondering if those individuals will also be offered vaccination in line, if we have to treat them like a care home, but the people in them are not as high up on the priority list as people in care homes. Or at least older people's care homes. So that's a bit of a conundrum for a couple of our members, just because of the kind of groups of people that they support. So I wondered if you could offer some views on that, please.
It's relatively straightforward. It's risk of death in the resident of this disease, not of other diseases. It's risk of death of this disease. So in the main, this isn't universally true. In the main, if you are young, even if you have other things going on, you are at much less risk than a care home resident, an elderly care home resident. They are the most at-risk group for COVID, as proven in this country and in many other countries. So no, they won't be vaccinated at the same priority grouping as elderly care home residents, but they will, many of them, be captured as we move down through those lists in the clinically extremely vulnerable group, then in the vulnerable group, and then by age.
Again, very, very clear. I'm just ticking off all the questions, Jason and Syed, as we go through this, and I think your answers to all of them have been, very straightforward and very clear. I'm just trying to pick up another few from the chat, and I wondered if I could come to Alison, who's been monitoring the chat with colleagues, just to see if we've missed anything. Alison, have you picked up something else that we haven't kind of got to yet?
I think that my colleague Nancy has one question, and then I will follow that with just a general question. Nancy, over to you.
Thanks very much, Alison. I actually have a couple of ones, but just wondered if Jason or Syed could give us an indication of what the transmission rates are for people who have already been vaccinated. And obviously it's probably early days for that, for you to know that, but if you could comment on that.
So we don't know. The latest study we have is still trial data. We don't have data out yet from the general population vaccination program because it's too early. And transmission studies are quite difficult to do because you need to follow whole households to see if Mary got the vaccine and she got a positive case, did she pass it on to other people? So that's the transmission level data. We know that in the AstraZeneca trial that was released last week, you were about 67% less likely to transmit, and therefore but that's in 17,000 people who were in the trials. So it's big, but it's not 12 million. So we don't know for sure, but it is very encouraging that what we all thought would happen, in that the vaccine would stop serious disease and also stop transmission, is proving to be true, but we don't know the scale of it yet. Syed?
Yeah, just to the reinforce that, remember, we already said to you that we got clinical trials showing that both all the vaccine protect against symptomatic disease. And symptomatic disease, as you know, this is a respiratory virus, and the main route of transmission for the respiratory virus is, as they say, coughs and sneezes spread diseases. So it's a cough and sneeze that really spread their virus, and aerosol as well. So if you can protect people, like, having the symptoms, clearly you are going to reduce the amount of virus circulating in the home and the environment. So there is no doubt, we are very hopeful it will have significant impact on transmission, but we don't want to make that claim until you got scientific data to back it up. Otherwise, you'll be saying, people will be saying, well, what evidence have you got? But as Jason said, the latest data published in the medical journal Lancet last week on one vaccine, AstraZeneca, they have showed that there are 67% sort of reduction in the transmission. So that's very, very encouraging sign. And certainly, as soon as we got some of the studies are underway completed, will certainly they'll be published in the peer-reviewed journal. But it certainly, all the indications are, it does make sense that if you're protecting people against symptoms, you're likely to prevent them acting as a source of infection to others. Over.
I find these, Annie, percentages quite hard to understand because what does it mean in the real world? So what is a 70% risk reduction in terms of serious disease mean? So 17,000 people in this trial, half got vaccine and half didn't. And then you follow them. They go about their business like the rest of the world. And you see if they get a positive case. If they get positive, you see if they end up in hospital. So you swab them every week and you follow their lifestyles. 17 people in the non-vaccine group ended up in hospital. We didn't give them the virus, they just caught the virus in life. None of the vaccinated group ended up in hospital, not a single one. But at the next level down, remember we do swabs on these people every week, about 27 of the vaccinated group, which is 8,500 people, got a positive test, but didn't end up in hospital. 84 of the people in the non-vaccinated group got the virus. 17 of them ended up in hospital. So that's where the percentage thing comes from. So you can still catch the virus. You're less likely to catch it if you're vaccinated. You can still end up with the disease. You're less likely to have the disease. And you might even end up in hospital, but you're much less likely to end up in hospital. So I find the percentage is quite difficult to translate into real world effect. But that trial's the best I've found to try and translate that for people.
That's incredibly helpful. Thank you. Nancy, you had another question that you'd picked up that we hadn't got around to yet?
Yep, just a quick one in relation to prioritization. And some members have care homes where residents are receiving their second dose this week. And they just wanted to check as to whether this was the current policy for care home residents only at this stage.
So we're prioritizing second doses in the same way we prioritized first doses. So care home residents first, and then health and social care workers second. So yes, unless there is spare vaccine going around, and it'll depend where you are in the country, some workers will be done, but residents first, particularly with Pfizer, because it's more complex, as you all know, to just logistically. So the same process of prioritization for second as we did for first.
Lovely, thank you. Can I ask Alison, you had a general question to come in because we're nearly out of time, folks. So Alison, go for it.
I shall make it very brief. Jason, it's really regarding communication. I think you can see from the numbers of people here the interest and the uncertainty around this. And a lot of our members and the workforce are getting, depending on the media they read, depends on the response that they get. So can you recommend a good source of factual information that allows workers to look at it without having to trawl through pages and pages of clinical data and backgrounds?
NHS Inform. NHS Inform is the go-to place for the Scottish Government and the NHS Scotland views on what this is, whether it's about the restrictions on your life or the new treatments that are coming up or vaccination. NHS Inform is the most up-to-date version of that. And it's got a lot more user-friendly in the last year. It's easier to use. It's got decent materials. Depending on your demographic, Young Scot is also hugely helpful. You maybe wouldn't show it to care home residents, but actually some of them would love it. It's a very up-to-date, very accessible way of getting information, and it's not just for young people. Louise MacDonald, who runs it, would want me to tell you that she's very happy for anybody to look at it. The more technical information is on the Scottish Government website, so that might be for leaders of your workers or institute or union reps, or so the actual guidance is there, but some of that is quite dense. So I would start at NHS Inform and Young Scot and some other places.
And just to say, there's those leaflet that Jason talked about in NHS Inform. They also got a lot of link in there. So if anybody want to go into more in depth, want to find out the headline or the science behind some of the headline data, they can also explore that further. One further thing I would say that, look, as Jason said, we have been giving vaccine for over 200 years. So vaccination, we give vaccine usually to people who are otherwise well, not ill. Therefore, we always take added precaution, extra precaution, and you always want to make sure the vaccines are safer than safe before this independent committee ever recommend such a vaccine. So I think, and you should be reassured to the fact that initially the vaccine was given to mainly senior clinicians and others who are in the front line, and we got uptake rate well over 90% among the clinical profession, and they are not going to, they are not going to take any risk with the vaccine, because these are people who have trained in science and they know how to look at and review the science as well. So there is absolutely no reason why any of your members should have any concern about the safety of the vaccine, because in the UK, as Jason said, we got one of the best record of giving vaccination. We got a large number of vaccine currently being given with uptake rate, some of the vaccine about 97, 98%. That's not because we make it compulsory, because some countries make vaccine compulsory and their uptake is quite low, mainly because people are suspicious. Our view is that if you got a good product, you don't have to make it compulsory. People will come and get it. And that's the way we see it. And the vaccine, as far as we are concerned, any vaccine we recommend in this country, they're safe. And the only reason we would recommend it to people, and would not recommend anything that we would not accept ourselves. Over.
Thanks very much for that, Saeed, and Jason as well. I think we have now, in fact, I'm sure we have now got through the whole list of issues and questions that were raised. And miraculously, we've done that 2 minutes before the end of our session, which I could not possibly have predicted, but there we are. So thank you to everybody for coming along today. I think and thanks to Mary for putting that link into the chat, because something that's kind of recurred in the chat all through this meeting really is, can we have the briefing? Can we have the information? Because we have a number of senior managers here today whose job now is to go and communicate this to their workforce, to their staff, to encourage uptake. And so that kind of clarity of information is incredibly helpful. So I think, colleagues, in closing, I would simply say that I think we're actually very lucky to have Jason and Saeed and colleagues in the Scottish Government, because not only do we have, a very high level of technical expertise here, but we have some really super communicators amongst us today. So thank you very much to you, Jason and Saeed, because I think you have delivered that with remarkable clarity and without any kind of equivocation. And what I think is really, really helpful is when you don't know, you say you don't know. And I think that's another thing that's going to kind of build confidence here. You know, not trying to give anybody any flannel here. We're trying to really communicate to the workforce the importance of engaging with this program. As I said at the beginning, we have noted a little bit of hesitancy amongst the workforce, but I think this kind of event and this kind of communication will really, really help us to break through that and achieve very high levels of vaccination in our workforce. So thank you very much to you. I hope one day we can invite you both back. Hopefully with more success stories about how this is going. You can see as the chat is scrolling up there, colleagues, I think how useful and valuable people have found that. So, you know, really, really grateful thanks from all of us at CCPS to you for coming along today. And thanks to everybody, and we'll see you again another time.
Thank you. Thanks for having us.
Thank you for having us.
Bye.